Madam Chairman, and thank you, each of you, for being here today. It is wonderful to hear from you on your perspective about what is going on. The FTC, with the work that they are doing, also looking at the vertical integration, and the access to different patient pharmaceuticals. And let's see, Dr. Pat and Dr. Offbro, I wanted to ask you about access to specific pharmaceuticals for patients and how the PBMs affect that and the choices that they are making, and how often are you uh, how often do you see this as a problem for patients getting precisely what they need for the period of time that they need it?
Thank you, Senator. And I'll say I work closely with Dr. Patton and Dr. Schleicher from Tennessee Oncology and the Community Oncology Alliance, so they're well familiar with these issues. We frequently see that PBMs in their insurance vertically integrated partnerships determine which therapies can be given first. I think a great example of that is in breast cancer, when I want to treat a patient with a class of drugs called a CDK4/6 inhibitor. There are 3 drugs that are approved on the market, and I might choose one because of very specific patient issues. One has better evidence for brain metastasis, one is not as good as if the patient has diarrhea, and I'm frequently not able to make those choices based on what's best for the patient because of direction and formulary restriction on the part of the PBM. In addition to that, frequently the PBM makes preferential choices that might be more expensive for the patient. So my colleague, Miriam Atkins, who practices out of Augusta, Georgia, prescribed imatinib for her patient with GI stromal tumor. The patient out-of-pocket cost was going to be $1,500 if run through insurance because of the way that they contracted with the brand name drug. But whenever they didn't apply it to insurance, and the patient wasn't going to take their medication, they were just not going to treat their metastatic cancer. Instead, they just sold it and ran it out of their office, and they were able to get it for about $150, and they were able to take the medication. So it shouldn't be the case that patients have more options by not using the insurance that they pay for. And these are some of the pivots that we're directed to because of PBM management.
Well, thank you for that, and thank you for mentioning Tennessee Oncology and the great work that they do there. We appreciate what they do in our community. Dr. Oberzoff?
Thank you, Senator. I would echo, we see the exact same issues in community pharmacy when patients and providers are restricted in their formulary choices, and one medication might be more appropriate, but it's not available to the patient. The other thing that we see quite a bit of is mandatory mail order, and it may be mandatory mail order in general or for specific medications that pharmacy benefit managers have deemed as specialty. And there may not be any clinical rationale for a medication being designated as specialty. It's just in the PBM's economic benefit to categorize it as a specialty medication. And when those medications aren't available to patients to access through the community pharmacy, that can lead to gaps in therapy. We've had this happen with patients in our PrEP clinic. We run a pharmacist-run clinic for patients who are to prevent HIV, and this requires labs and then daily medication. And when they go without that medication because it doesn't show up in time in the mail, they have to restart all of that lab work. It's additional cost to the Medicaid program and the health insurers.
So listening to the two of you, PBMs actually get in the way and prohibit proper care. Let me ask each of you, if given the choice, would you completely eliminate PBMs?
I think all that we're looking for is to see that PBMs are regulated in the same way that the rest of us are as healthcare providers. They're a part of the healthcare system. They need to be regulated, and we need a fair landscape.
Okay, Dr. Pat?
It's so tempting to say that I would completely eliminate PBMs, but the truth is, I don't know that that's the right answer. I think it would improve upon things currently. I will say that I take issue with the analogy of PBMs being like group purchasing, like you would see with a Costco, because I think that analogy only holds if Costco is the only place that you can shop. Because the challenge is that discounts that PBMs negotiate may not be translated to employers and patients. In fact, we don't see evidence that it is. In contrast to the Costco analogy, where shoppers have the ability of choice. We don't act like that in healthcare. So it's a limited analogy, and while PBMs might purchase at discounts, we need to see evidence of where those discounts are going. And I suspect that they're not going to patients and employers. At least when I talk to patients and employers, we don't see any evidence of that.
I'm yet to find a patient who says a PBM has saved them money. I have found many patients who tell me the PBM would not allow them to have what the doctor prescribed. Thank you so much for being here for our hearing today. Thank you, Madam Chairman.
Colorado.
Thank you, Mr. Chair. I want to start, first I want to thank you all for being here.